for practices that are seeing these, models like this out there where it's, a 1-year project and it's a commitment, so much comes out of that. I mean, we learned so much that has outlived the program, and we've expanded on the things that we've done, and the staff felt empowered. Our patients were impacted. So I would say just do it. It seems scary, doing these models and you're having to report data and capture data, but you learn so much as a practice and the things that do and don't impact patients so that you can really figure out, how can we make care better? And that's everyone's ultimate goal.
On this episode of Cancer Buzz, how programs can analyze and improve lung cancer care for the Medicaid population. What you need to know is next. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Despite advances in diagnosis and treatment, lung cancer remains the leading cause of cancer-related death in the U.S. And outcomes are more bleak for minority populations, the underinsured, and those on Medicaid. When it comes to patients on Medicaid, navigating all that comes with cancer, like finances, appointments, and treatment, is a constant challenge. On this episode, we hear from 2 cancer programs that were looking for a better way to care for Medicaid patients with lung cancer. Working with ACCC, these programs started quality improvement initiatives based on a model that's now available to you. The care coordination model took 3 years and a team of multidisciplinary experts and cancer program staff to develop and test. You heard from Amy Ellis earlier in the show. She's the Director of Quality and Value-Based Care at Northwest Medical Specialties, PLLC, in Washington State. We asked her what their goal was in undertaking the project.
The goal at our practice was actually to implement a navigation program. So every practice that was in the OCCM model essentially got to come up with their own version of the optimal care coordination. And our proposal was that if we implemented lay navigation into our cancer center, would that reduce the ER visits for the lung cancer Medicaid population?
And did it? What did you learn?
Well, unfortunately, it did not. So we were pretty surprised by that, actually. Going into the model, we ended up hiring a non-clinical person. So we called that a clinic navigator. And then we also assigned an RN case manager to these patients. And we were not successful at reducing these ER visits, which was very surprising because we assumed that if you added these additional layers of support for these patients, that we could be successful at reducing those ER visits. But what we found was that patients were extremely difficult to get a hold of. Oftentimes we would have to, call a patient's family member to tell them to call us back, frequent missed appointments, frequent calls out to the patient who wouldn't return our calls. And so there was a lot of socioeconomic barriers that we face. And I think another thing we learned was really if patients aren't engaged in their care, then they may not be successful at some of these things, like, reducing their ER visits. Because if they aren't willing to improve their health or, adhere to the care plan that's given by their provider, they may not be successful.
Knowing that and knowing the challenges and the new things that you learned from your patients and how they consider their health and the effort they're willing to go, how did working with the model and completing the project impact the way you will treat your underserved patients in the short term and in the long term?
Yeah, so this model was so beneficial to our practice in so many different ways. We learned a lot about ourselves as care providers and having to learn how to communicate to each other in difficult situations and dealing with patients that may be difficult to reach. We actually showed while we did not reduce our ER visits, which was our end goal, we were able to show that we were able to improve the patient's experience by providing, housing resources, transportation resources, even food security for these patients and helping them get meals. And so we were able to prove this impact to our leadership teams and our stakeholders at our practice. And we actually got approval to keep this position on, this lay navigator position on the OCCM model. And then we actually expanded expanded that further. And now we have 2 lay navigators at our practice. We have 5 locations. And so we've got one assigned to 3 locations and one assigned to 2 locations. And so that impact of OCCM, and because we were able to see how beneficial it was to have this position at our practice, we were able to expand that and actually have that, even currently, a couple years past the model.
Do you have any specific patient stories that you can share with us about what you learned about them during the program?
We actually had a patient who she's homeless, and we actually had this navigator setting up the ORCA. So we have an ORCA pass. An ORCA system is kind of like the public transit in our area. And so this navigator, because this patient didn't have an address, we actually would work with the ORCA system and the paratransit system to pick the patient up at a specific intersection. So we would say, this patient will be at this intersection at this time. And, if this person who was homeless did have a mobile device, thank goodness. So we were able to coordinate, this paratransit program with the patient and have them meet at this specific location, even though they were homeless, so we have a lot of stories like that.
You talked about you learned a lot about yourselves within the program and how you communicate to each other and to patients. What did you find most useful about working with the model? And then can you see this model being applied to Medicaid patients in other oncology practices in your program?
One of the most beneficial pieces of the model was that when we applied, they basically gave you, we worked with Memphis University and the ACCC, and they basically gave you the outline of here's all the things that we would consider being in this optimal care coordination mindset. So they gave you, almost like templates for care and all the things that if you wanted to be at level 1, these are the things your practice would be doing. If you wanted to be at level 3 or level 4, now level 4 was the top level. And so we always aimed for everything. We wanted to do everything in every level all the way up to level 4. Some of that we weren't able to implement into the practice, but that was one of the benefits of doing that model. And one thing that we were able to learn from these templates was here's the best practices. We did modify them for our specific workflows and protocols, but it was extremely beneficial to have those outlines. And then we'd have our team, communicate on, okay, the OCCM model says that level 4 means this. How can we get there? Let's work together and brainstorm. How can we make sure that the patients have, this service at our practice? Or one of the items on level 4 that we were not able to meet, which we're still kind of brainstorming, was essentially a multidisciplinary tumor board. We do have that in one aspect, but the level 4 had it much more involved than what we were able to do. And so, being able to say, here's what we need to achieve. How can we kind of baby step and get there? That was definitely one of the things that we learned throughout the model. And then I absolutely think that not even impacting Medicaid patients, with lung cancer, the things that we've learned in this model, we've already implemented to all of our patient population at our practice.
So I'm thinking that you would go through it again, despite the big commitment that it required.
Oh, absolutely. I actually, we keep our eye out for other models like this. We absolutely would love to do other projects like this. I think breast cancer would be a really interesting one because there's, the survivorship population and those patients are living so much longer. And so that adds an absolute facet of complexity of care and, the longevity and really looking at things long term. So I absolutely think that we would, participate in other models like this.
Now that we're in the middle of a health emergency that our country has never seen, how did going through the ACCC model affect your communication about care during COVID with this patient population in your whole practice?
Well, I think that the processes that we put in place for the OCCM model have been absolutely impactful during this COVID-19 crisis because we have those lay navigators in place and we have this really solid navigation program. We constantly have patients calling all day long. People are out of work. They don't have childcare. They don't have incomes, more than, ever. And they're needing so many resources, food, housing, you name it. they need resources right now. And this is not just Medicaid and lung cancer patient populations. This is all of our patients being heavily impacted by this, whether it be, losing your job or getting furloughed, and now you may lose your health insurance. I mean, these are major issues that we're facing. And these lay navigators, that is their job. Their job is to find resources. They have their bag of tricks and, hundreds and hundreds of resources for patients that they can provide and try to help keep patients supported throughout this. And so they've been really impactful, not just to the lung cancer Medicaid population, but this foundation that the OCCM model built for us has really helped us throughout this crisis.
Thank you to Amy for her perspective. Wendi Waugh is the Administrative Director of Cancer Services and Community Health and Wellness at Southern Ohio Medical Center. We asked her about the program's experience using the tool.
When we started looking at the model, we had been measuring detection to diagnosis and diagnosis to treatment actually for a few years within our center. And we'd made quite a few improvements just getting the patient to treatment quicker, but we kind of come to a plateau in that we weren't able to improve that anymore. And we really didn't know enough about the data to know really where we were falling down. So I'm not quite sure what we really expected we would learn about the model, but we learned really not only how to better measure detection to diagnosis and diagnosis to treatment, but to really parse out and get little bite-sized quality improvement, things that we could take and process map things, I think, better.
Did the model make you aware of ways to improve care that you hadn't even previously thought of?
It absolutely did. And in fact, the model was really the largest catalyst in our organization to make the case to add more navigation services to our team. So our lung program actually started on the screening end of things, and we had a screening navigator, but we did not have a navigator on the cancer end of things. So we really learned by looking at some of that data what we could do by putting a navigator in place, and it really was beneficial.
So you said that it was really glaring that you needed some navigation services to be added to your program. How do you think it's going to impact your program, not only with those navigation services in the short term, but what about the long term?
Well, one of the first, I think, long-term things is it really opened up leadership size, because I think ACCC does a great job of not only wanting to work with the people who are going to get the data, but involving executives and providers at other levels in the whole project. And so everyone really understood what we were doing and what we were trying to do. And I think that's sometimes important for understanding of the data at presentation. So that was one thing that I think was critical that we did.
In all of your findings through the model, did you find anything that was applicable that changed the way that you addressed your patients during the pandemic, for instance, with this population?
Well, I can't say necessarily through the pandemic, but I can say that when we started in the model, we actually developed a spreadsheet to manage our patients in. And that spreadsheet continues to live today. So it's one way that our navigators keep track of the patients that we have. It's one way that they are able to follow back up and see what junctures, what treatment measures. And we continue to report to Cancer Committee on a quarterly basis how we're doing on D to D and D to T, and continue to improve those. So not only did we add extra support for cancer lung navigation, but we also were able to begin our incidental nodule program. And we learned so much by the way that we structured the D to D and the D to T that we again took a subset of patients and we looked at them to say, okay, we had 100 patients here, and prior to navigation, only 20% of these followed up with their pulmonary appointment when they had something that showed up on their ED visit. And then we did 3 months of let's try navigation with another 100 patients and see what kind of follow-up rate we can get with a pulmonary appointment. After that, it was over 70%. So you can see that we really were able to follow, manage, and you really do have to bother these people, bug these people, help them understand why they need to come to their appointments, figure out. And then when they don't come, you got to call them back up and reschedule them and say, come on now, you got to come. So I know it's silly, but this is the kind of attention a certain population needs. Not everyone needs that, but there is a large population that do not understand the importance of that workup and follow through for appointments.
What about any challenges while you were going through the model?
I mean, the challenges that we joked about with the ACCC team, and it was essentially that we are a relatively small rural community hospital. And it did sort of take a lot of our resources to really get all the discrete data and really measure this and look at it in an objective and scientific way. And so for us at times it was frustrating before you could see that light at the end of the tunnel and what was all this really going to mean. So that was a challenge, and it was a challenge, giving those resources up front prior to knowing what the result would be.
When you were going through the model, what did you learn about your program that just excited you the most?
I think what excited us the most, to be honest with you, is just the increased awareness of the whole team. We actually formed a lung health leadership team that continues to meet regularly still today. And, those increased services and navigation that was born out of participating in the model is really invaluable.
The care coordination model that these two cancer programs use to model their QI projects is now live and available for you. You can find more information about the model in the show notes. Thank you for supporting Cancer Buzz. If you enjoyed the show, please leave us a rating and a review, and share the episode with a colleague. Ratings, reviews, and referrals help us to continue to bring you the latest trends and resources in cancer care. Next week on Cancer Buzz, we'll take a look at how the coronavirus pandemic has affected safety measures and protective equipment at cancer programs. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.